Go ahead and start our afternoon together. Good afternoon, everyone. My name is Jim Kinsey, and I am the director of the Healthcare Experience Academy. And I'm so happy to have all of you here with us today to hear this important topic and a little bit about a collaboration that we all have had in the last couple of years with Nuvance Health. I'd like to take this moment to do some housekeeping and talk a little bit about the flow of our time today. And that is going to be very simple. I am here with my colleague and friend, Kim Bixler. Kim and I are the host and co-host of our time together. And we are joined by Alex Winters from Nuvance Health, who will be our main presenter. At the Healthcare Experience Foundation, a lot of what we focus on is how we're able to assist and help organizations really create what is necessary for them to achieve the success that they would like to achieve. And in order to do that, we offer an array of services and we offer an array of collaborations that are really coached and driven by our team of experts in the field of patient experience, also in the field of leadership and operations. One of those collaborations and partnerships is part of, if not the main crux of today's organizational approach to reducing readmissions. Alex is going to talk with us not only about their journey, but also about um, a product that they're using, a solution that they're using called Cares Connect. And Cares Connect is a partnership between the Healthcare Experience Foundation and PRC. And its goal is to advance transitions to home and bolster patient loyalty.
Mm.
This is going a long way in order to improve those key transitions that we know our patients experience. So Alex, if you want to click for me and I'll introduce you. Alex Winters is the Assistant Vice President of Patient Experience at Nuvance Health. You can read a little bit about Alex on the screen, but one of the things that I wanted to share with everyone is that when you talk about collaboration and we talk about how people can collaborate across multiple formats and multiple ways of communicating. That's my experience with Alex. So Alex and I had one Zoom meeting and have put together this entire thing by email. And so never underestimate the power of technology when collaborating. So Alex, welcome. Pleasure to have you and take it away.
Thank you so much. What a nice introduction. And I think, that really highlights a key point that I want to make throughout this conversation is sometimes the solution that you think is the best solution, like putting a presentation together through email, is truly the best solution. And I love that we started there, Jim. So let me tell you a little bit about our journey here at Nuvance Health, um, why we chose to go with Cares Connect, what we've learned along the way, and then most importantly, the results that we have seen as a result of this partnership. So I start here with a quote. The truth of the matter is, you always know the right thing to do. The hard thing is doing it. And I start here because most of you, right, if you're sitting here on this call, you know post-discharge phone calls are best practice. They are best practice in multiple areas. They're best practice in reducing readmissions. They're best practice in keeping our patients safe. They're best practice in improving communication scores and patient loyalty. So we at Nuvance, right, we knew this. We knew that executing post-discharge phone calls was the right thing to do. However, executing it with consistency and a very high quality standard was a real big challenge for us. So we really had to think about, how do we do the right thing here? And the problem for us is when we started having this conversation about post-discharge phone calls, we were right around 2020, 2021. There was a lot going on at that time. Our country or our world was in crisis with COVID-19, and we were not unique. We saw incredible challenges. When we thought about the problem in post-discharge phone calls, we were seeing the impact of COVID-19 on our HCAHPS scores, like many of you. We declined significantly. Our readmission rates were going up. And so we really had this complex problem that we needed to solve, and we couldn't figure out how to do it. We thought first, maybe we'll just use our current staff, but staffing challenges prevented post-discharge calls from happening and from happening consistently. Next, we were a super young organization at that time, or I should say we still are a young organization. We had merged in 2018, and so we were 7 hospitals coming together with very different ways of doing things. Our EMRs didn't talk to each other. And so there was a decentralized model. And so what this really resulted in was inconsistent actions. Some patients got a post-discharge phone call, some didn't. Some unit leaders were really passionate about it, some weren't. And inconsistency, for me, is really the crux of failure. When we are inconsistent, there is no way that we can improve. So we started thinking about what are our solutions? What can we do? And our first thought was, we'll use our nursing leadership teams. We will mandate that each nurse leader calls 100% of their discharged patients and that they do this consistently. This was very quickly thrown out for many reasons. The first, many of them were in assignments at this time. Next, we saw inconsistent skill levels. And we knew that if we wanted this done and we wanted it done well, we would have to put a process in place where a post-discharge call was conducted in the same manner each time. So then we fast forwarded and we thought about our light duty and our COVID restricted nurses. And people who couldn't necessarily work or having to work from home, could we use that team? And we thought through that, and ultimately we decided no. Primarily because we knew that that team would see heavy turnover and we'd have to consistently train and educate. And we, again, were worried about the quality, the standards of excellence that we had. And so next we thought, all right, we'll create our own call center. We will hire a whole bunch of people, we'll bring them in, and we will use our own people to execute here. And we found that cost would really prevent us from doing that. And so after a while, I began talking to my friends at PRC, and we thought through the process of Cares Connect, which is a post-discharge phone call solution that we offer to 100% of our inpatients who are discharged home. And when we thought about Cares Connect, we really wanted to work through what would the process be? How would we do this? Because we knew that we would have patients who would need to get back to the hospital, who, when that post-discharge phone call came through, they would say something like, you know, I'm not really sure about how to take my medication, or I'm in a lot of pain, or I'm not feeling well. So how could we use our partnership, but make sure that at a local level, we still were integrated into the care we were providing to our patients? And so we put this process in place. First, we sent a daily file to PRC with all of our discharges. And then I'm so proud of this metric or this capability. PRC would call 100% of those patients who are discharged home within 24 to 48 hours, an immediate check-in on our patients. Next, in real time, PRC would post issues to an internal website that we share, letting us know someone's got a problem. our team would be empowered to, oops, sorry about that. Our team would be empowered to resolve that problem. And we put a very ambitious goal in place that we wanted to call our patients back and resolve their problem within 24 hours. And all of this feedback loop and this service recovery process was all done well in advance of our patients getting their HCAHPS call. And that was done very deliberately. Now, when we initially started, we thought about, well, what will we ask our patients? And we chose to ask some pretty standard questions, focusing on health status, discharge instructions, medications, follow-up, contact request, and special attention. And special attention really was a flag for our team at PRC, our interviewers, to alert us that something didn't feel right. Now, these questions were quite successful, but we learned a lot using them, and we learned about how to optimize them. So let's first talk about what did we see with our post-discharge calls, our initial data when we first launched. So first, if you take a look here, something we're so proud of, we reached almost 20,000 patients. 20,000 patients. And that is a number that I think we should all reflect on. Because those are 20,000 patients that pre-CARES Connect, we were just letting go home. If you come down and you look through this chart, you'll see we very quickly learned that we had significant opportunity. And when we think about significant opportunity, we're thinking about things that were impacting or had the potential to impact our patients' clinical outcomes. So I'll draw you first to that 17.1% of patients requesting a callback. When we initially started our conversations with PRC, we were told that number would be closer to 8 or 9%. And so 17.1 was a huge red flag for me. And what that really demonstrated to me was, are we doing a good enough job educating our patients and having them leave with confidence? Because a lot of them want to talk to us again. When we took a look at where were our biggest opportunities, we immediately found that our biggest opportunity had to do with the critical action of scheduling an appointment after they were discharged. 32.2% of the patients we reached told us they were struggling. They needed help in scheduling their follow-up appointment. That was really jarring for us. In addition, we saw significant opportunity for medications and opportunity to better explain our discharge questions, our discharge instructions. And when we dug through this even further, we saw that we had opportunity further in our medication questions and our worsening symptoms and help with our appointments. And I think we can agree that all of those things, right? I have a question about my medication. I'm not feeling better. I'm actually feeling worse. And I can't get in with my primary care doctor. Those are all reasons that patients end up readmitted. And so when we started to think about lessons learned, this quote really came to mind. Something I tell my team every day is, it's okay to fail, but you got to do it real fast. And this quote, fail early, fail often, always fail forward. We were learning from our post-discharge phone calls, from the results of our post-discharge phone calls. And the key opportunities that we found, first, were ownership of escalations. I shared with you in the beginning of this conversation that we had a goal of getting back to our patients within 24 hours. That was not happening. And that was a really big problem because that was a broken promise. Our colleagues at PRC were doing an excellent job of taking a patient's concern, letting that patient know Nuvance Health cares about you and they care about your feedback. They will get back to you within 24 to 48 hours, and then we weren't. And so that was a really big problem. An additional opportunity for improvement had to do with the number of escalations. 17.1% of those patients were escalating, and that had a lot to do with both processes, internal processes that we had, and in addition, the way we were asking the questions. And then finally, we saw that we had opportunity for our types of escalations. And so what did we do about this? Well, we redefined what an escalation was. We redefined what Nuvance wanted to know about and what would be more appropriate to filter to a patient's primary care provider. We outlined that escalation and we updated the call scripting that our colleagues at PRC were using. When we did this, we connected with key stakeholders, specifically with our VPMAs and medical directors of our hospitalist teams. And we had them review with us the scripting that we were proposing and had a lot of tough conversations about where should an escalation go. If a patient that you discharged 3 days ago is saying they feel worse, should that come back to you or should you be referring that to their primary care provider? We also talked about our proposed changes with our PFACs, our Patient Family Advisory Committees, and made sure that we were considering the patient's voice in these actions. And what did we see? We saw a significant drop in escalations, down from at a system level, about 18.7% down to about 13%, much closer to that 8 or 9% range that we initially heard when we talked about operationalizing this model. Here again, we see what really changed. And so you can see our discharge instruction questions, the percentage of escalations there, we really see a shift. But we did see a significant shift in our patient picked up prescriptions, our started taking medications, our follow-up appointment, and our special attention. And this was really important because we wanted to make sure if we were providing an escalation and we were assigning that to our team, that it was a valuable use of their time, that it was a true escalation. So now let's talk a little bit about the unexpected benefit of our post-discharge phone calls. We saw a whole bunch of benefits. We saw it improve our patient safety, readmissions, quality, and for me, right, a huge win of improved HCAHPS scores. And so what I'll first draw your attention to is the impact that a post-discharge phone call has had on our HCAHPS scores. Our goal here at Nuvance Health is surrounded around the likelihood to recommend question. How likely are you to recommend this hospital to your friends and family? We're very focused on that because we believe in patient loyalty. We know how important that is. And when we launched Cares Connect and when we made those changes, we have seen a 5% improvement in likelihood to recommend for patients who receive a Cares Connect call and complete a Cares Connect call compared to those that don't. So if we had 2 patients in a room right next to each other, both received the same care, had the same experience, but one answered that phone and went through that Cares Connect call, and the other didn't, we would expect to see that patient who completed that call rate us 5% better. Now, I'm real focused on what are initiatives that I can do that impact not just likelihood to recommend, but that impact the whole scorecard. right? I want my teams focusing on high value initiatives. And Cares Connect is one of them. It impacts every area on the survey. Not just by a little bit, but by a lot of bit. Look at our doctor's score, our nurses' score, care transitions. Patients report a better experience in all areas of the survey, even cleanliness, when they complete that post-discharge phone call. Here is just another view of that. Really, that shows the difference between a patient who completes a call and doesn't complete a call. But what this has really done for us is we have taken Cares Connect and added it to our patient experience toolkit as an evidence-based best practice that we know improves those HCAP scores. And so the question I ask now is, well, what if every patient answered? If every single patient answered their post-discharge phone call and completed their post-discharge phone call, what would happen to our patient experience scores? And I've been thinking a lot about that because a patient experience score is not just a metric. The evidence suggests that when we have better patient experience scores, when we communicate more powerfully with our patients, the clinical outcomes are better. And so really, this is about taking better care of our patients. And so what if we did one thing different and we made sure every single patient completed that patient experience or that Cares Connect call? Now, another thing that I am just over the moon focused on is that responsiveness or that response rate. We've done really well in this space, well above industry standard. But our goal is to get to 75% of our patients who receive a Cares Connect call to complete it. We feel like when we're there, then we're going to be making a significant enough impact on our HCAP scores. And I wanted to share with you here where we have put a little bit of work. So I told you before that we identified multiple areas through their Cares Connect calls that were barriers for our patients. They were pain points. And we saw some really significant pain points in our medications and in our follow-ups. And I'm really pleased to share with you that we have reduced our escalations in those two spaces through some really deliberate action. Our medications, we have put in place processes in which we have our pharmacy teams round on patients who will be receiving new medications to truly make sure they understand the purpose and are comfortable picking up those medications. We also focus on relationship-centered communication here at Nuvance Health. And a key component of that communication is how do we make sure a patient understood? And there's 3 best practices that we talk through. First, checking for barriers. Next, preference and getting the patient to say yes. And so we have trained all of our team members when they're talking about immune medication, first to ask about preference. There's a whole bunch of medications out there for hypertension. Here's a few that I like. Let me tell you about them. Now you, as our patient, make the decision. What do you think would work best for you? Preference, let them decide. Next, barriers. I need you to take that medication starting today when you're discharged. Anything that's going to prevent that from happening. And we're looking for things like, I can't afford it. I don't have a ride. I'm not sure I understand that medication. Am I comfortable taking it? We want barriers and we want to address those barriers. And then finally, we get that patient to say yes. We know that when the patient says yes, they are way more likely to be compliant because they trust us and they've made a commitment to us. So we're going to say something like, okay, you chose medication A. There's no barriers in place to prevent you from picking it up today. I want you to start taking that medication today. Is that a plan for you? And we want that patient to say yes. We've put that process in place with our pharmacy teams based on a direct correlation of the pain points that we learned from our Cares Connect calls. Next, we have really partnered with our primary care teams to reduce friction when our patients call in to schedule. And one of the ways that we've done that is partnered with our primary care teams who have open access across the system. And what that means is you might not be able to get in with your doctor in Poughkeepsie, but I can certainly get you in with their trusted colleague in Fishkill. This has dramatically improved, first, our CGCAP scores surrounding access, but also have improved our patients' ability to schedule that follow-up appointment. And what have we seen based on that work? Well, we've seen that Nuvance patients who complete a Cares Connect call have lower rates of readmission, significantly lower. If you take a look at this chart, and you can see that our patients who completed a Cares Connect call were readmitted at about a 5%, while those who did not were readmitted at about 9%. And we see that same correlation with our higher risk patients, so even our very sick patients. We see that when they complete this evidence-based best practice, they are readmitted at a lower rate. And so what we're doing here at Nuvance Health is taking this best practice for patient experience and using a multidisciplinary approach to tackle other key challenges that we're seeing. And what that allows is for multiple voices with different priorities to gain buy-in for a tactic that influences multiple areas of opportunity for us. What we're also doing with this work is using it to track our care partners. Care partners are people who are identified at the time a patient is admitted. And this is somebody who's going to help them during and after their hospital stay. Now, we want to make sure that care partners are identified and that our patients remember that this happened. We track it when we identify them in the hospital, but that's us tracking it. We want to also make sure that our patients remember, yes, a care partner was identified. And we're seeing that 78% of our patients can remember and acknowledge a care partner was identified. This is tremendous. And what we're now doing with our care partners is focusing huddles that are multidisciplinary, include case management, nursing, our physician team, to tackle some of our more complex diagnoses. What we're calling this is a care partner huddle. It happens before the patient is discharged to make sure that everybody is on the same page. And what we're seeing is that this is dramatically reducing readmissions and also improving patient experience. So again, that multidisciplinary approach, two different departments really coming together to tackle some of our more complicated areas of opportunity. Okay. That concludes my presentation. Are there any questions that I can answer? I thought I saw the chat going a little bit. Let's see if I can get to it. Are there any questions in that chat? Oh, would the deck be available? Of course. Are there any other questions that I can answer for you all?
Alex, I do have one question
Yes.
that I was thinking about as you were talking. You made the distinction between receiving a Cares Connect call and completing a Cares Connect call. Could you just explain the difference between those two statements?
Sure. So we reach out to 100% of our patients who are discharged, right? And we are very deliberate in making sure that our patients know that this is a safe call to answer. The caller ID says the hospital exchange. So for example, Poughkeepsie is an 845 area code. It's an 845 exchange. And the title that appears on caller ID is something like Vassar Hospital Cares, Danbury Hospital Cares. Now, we want to make sure that our patients know that call is coming, because many patients see that and they think it's a bill, it's spam. I don't really have time for this. This is going to be a lengthy conversation. And so we don't want our patients just to receive that call. We want them to complete that call, go through all 5 of those questions. And so that really speaks to that response rate goal of a 75%. We want to make sure that our patients pick up, answer, and complete.
Thank you for that. And I just have one last final question. You talked about the collaboration with your patient family advisory council. And I wonder if you could just share an example of how that work ended up having a better outcome for all of you because of their inclusion.
Absolutely. So we have patient family advisory councils at all of our hospitals. We brought our change in scripting to each one of those hospitals and talked about what's the scripting now and where does this escalation go? What's the scripting going to be and where does this escalation go? One of the big, I'll say points of contention was what to do if a patient said their symptoms are worsening. Who should get that information? Should it be the hospitalist who cared for them? Or should we be directing our patient to, I'm so sorry that your symptoms are worsening, call your primary care provider. Our hospitalists felt ownership there. So did our primary care providers. Those are our patients. We want to know. And so we really asked our patients, who would you want to have this information? And from a vast majority of them shared, primary care, I want my doctor who cares for me to know that I'm not doing well after I left the hospital. And so that really shifted the way that we managed that algorithm. Now, from a hospital perspective, I still report out on it. I can see the percentage of patients that say my care, I don't feel well after I leave. That's important to make sure that we're monitoring that and we're setting clear expectations about what you're going to feel like, and we're monitoring the quality of care. But we've shifted where that escalation goes so that people who spend the majority of their time taking care of these patients and have relationships with them are owning their care once they leave the hospital.
Thank you for that.
You're welcome.
I'm going to turn the program over to Kim, who will close us out for the afternoon. Take it away, Kim.
Thank you very much. Jim, just confirming, can you see the slide that I've got up? Am I sharing?
You're sharing.
Well, again, so thank you all so much for joining. And Alex, thank you so much. It is always so wonderful to have, clients and partners that are just willing to share their successes with others. And again, we are so proud of the CARES Connect solution. And we understand our team has been I've personally been in the industry over 17 years. And, we know that discharge calls are truly a recognized best practice that drives quality, safety, and experience. And this CARES Connect solution is a partnership between Healthcare Experience Foundation and PRC to really help advance safe transitions home and to bolster patient loyalty, which you heard the extraordinary impact that it had for Nuvance and your patients and community. So thank you. And the slide I'm showing is the average client improvement that we see for all of our clients that use this. Again, really reducing readmission penalties, having an impact on their VBP and their HCAP scores. So it's really a powerful solution. We'd like to, again, thank you so much for joining. And please reach out if you have questions or if you would like us to provide specific information about specific to your organization, how this solution can impact your readmission, your VBP, and improve your HCAP scores. So I'd love to share that with you, put something together specific to your facility. On behalf of our coaching team here at Healthcare Experience Foundation, again, we are pleased to share this information with you in any other ways that we can help you in your experience work. We work with clients all over the country with their patient experience, physician engagement, experience for employees. So we are here for you. Some things that we have coming up, just March is right around the corner. I can't believe how fast this year is going. Coming up, we have our Physician Leadership Certificate program that's starting in March. It's 3 sessions. You can scan the QR code for more information on any of these events, and we'll have a full calendar of events also on our website as well. Here's more information. This is a great program. It does give CMEs to your physician leaders. Really passionate about the work we do. And there's other ways that you connect with us as well. We do have our podcast, our Healthcare Experience Matters, which is a great podcast. I'm very into podcasts now, so I've added this to my rotation. Find us on LinkedIn. We are always sharing updates of what's going on in the industry or where you can find us. And again, more information about our certificate programs or how we can help coach your organization. So thank you again. It has been a pleasure. We will send out the recording to all the attendees, and I'll PDF the slides, and we'll get this presentation over to you. Again, please don't hesitate to reach out if you have any questions or if we can assist you in any way in the future. Thank you for sharing your time with us today.